Dr. Arif Siddiqui, who will be the chair of the session today, and Dr. Fawad Randhawa, he's a professor of endocrinology, and we have got Dr. Shahid Sattar Ahmed, who will be giving an online talk from US. So he will be third in line. So I would like to invite Dr. Arif Siddiqui. He's a principal in Rashid Latif Khan University Medical College, and he has been an ex-president of Pakistan Society of Endocrinology, ex-president of Pakistan Society of Hepatology. I think some of you who have studied from Allama Iqbal Medical College will know him very well. If I keep going through his credentials, it will take me quite a long time. So I'll invite him to start the session today with his first talk, and I'll leave the mic to him. Slide. Slides, I think we will move from here. Yes, we can move from here.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Shaukat Khanum, Cancer Hospital. Thank you very much, Dr. Ahmed Imran, Scientific Committee, Organization Committee, for giving me this opportunity to interact academically with you. Today's topic is GI bleed, a not so common cause. I have no financial disclosures. I have to disclose that I've taken the help of Google to search reference articles and snip some images. And I've also instructed ChatGPT to draw some figures for me. So I start the talk with a real-time story of a 58 years old man. Actually, his wife was my patient for a long time. The husband reported to me with 1-day history of heavy GI bleed. His wife had recently died of hepatitis C related cirrhosis. After initial resuscitation, an endoscopy was performed which showed no esophageal varices, no fundal varices. Stomach was partially filled with blood. There was a protuberant mass in the body showing signs of recent bleed. Diluted adrenaline was injected peripherally. A careful edge biopsy was taken. In the next 24 hours, he stabilized, but unfortunately, he left against medical advice. Few days later, on inquiry, I found out that he had bled again torrentially and died later in a local hospital. His biopsy had returned, showing he had features of GIST, G-I-S-T. So that is my main topic today, and we'll just review this tumor. GIST stands for gastrointestinal stromal tumor. So back to the basics. As all of we know that every tissue, every gland has a parenchyma, which are the main functioning cells of that tissue or organ. And it has got a stroma, which is the structure or the scaffolding on which the parenchymal cells are arranged in a certain pattern, which helps that gland or tissue to do its function. So I got ChatGPT to draw this figure for me on my instructions. So this is a cross section of intestines. This is the epithelial lining in brush border, and here is the serosa. Next to the serosa are the two layers of smooth muscles, circular and longitudinal. And this light pink area, this is basically called lamina propria. Within this lamina propria this constitutes actually the stroma of GI tract. There are some acellular objects like collagen fibers, elastin fibers, hyaluronic acid, and other acellular material. But in addition, it also contains various types of cells. These cells are of mesodermal origin, and therefore they are called mesenchymal cells. And these cells interest us as far as GIST is concerned. There's a long list of mesenchymal cells. I'm just taking first 5. These are the interstitial cells of Kagel. They sort of act as the pacemaker of the intestines and govern the peristaltic activity. Then you have fibroblast-like cells. They are also involved in neuromodulation. Then you have the smooth muscles, which do the contractile functions. Telocytes, they support the intercellular signaling. Endothelial and pericystic cells, which line the blood vessels. Uh, and mesenchymal stem cells are also present here, which are the multipotent progenitor cells. Just originate from intestinal cells of Kagel or cell of this lineage. So they originate from the middle layer of gastrointestinal tract. How common are these? GIST is a rare tumor of GI tract, accounts for only 0.1 to 3% of all GI tumors, and internationally has an annual incidence of 10 to 15 cases per million. I was able to pull out an article from Aga Khan University published in 2015, Asia Pacific Journal of Cancer Prevention. Between 11 years, 2003 to 2014, they retrieved, this was a retrospective study, they retrieved 255 cases of GIST, out of which about 59% were males, rest were females. The mean age was 16 years to 83 years. Sorry, the age range was 15 years to 83 years. Mean age was 51 years. But 70% of people, they were in the age range of 40 to 70 years. GIST is a very quiet tumor to begin with. So the average size at diagnosis that they found out was 10 centimeters. They had spindle cell morphology, and sometimes they are confused with leiomyomas and leiomyosarcomas. But if you do the immunohistochemistry, then differentiation becomes easy. So most of these cells, GIST cells on immunohistochemistry are CD117 positive in 98% of cases in this study. This means that they will be that tyrosine kinase inhibitor group of chemotherapeutic agent will be successive in treating these tumors if they are CD117 positive. So this was some local data. 60% of the tumors, they occur in stomach, about 30% in small gut, and rest 10% combined in colon, rectum, and esophagus. Stomach tumors are less malignant. Small gut tumors are more malignant. As I said, they are very quiet tumors, and sometimes they are found incidentally on CT or MRI scan of the abdomen, or incidentally on doing a gastroscopy. You are doing gastroscopy for some other cause, and if you are careful, if the inner lining of the stomach is clean, devoid of froth and saliva, they can be seen as smooth bulge. I'll show you the pictures. But these are symptomatically quiet. Most common presentation of GIST is gastrointestinal bleeding. So whenever you are attending a case of gastrointestinal bleeding, keep this in mind, this diagnosis in mind. It will come way down in the list, but still you might come across, as I did. They may, sorry, मैंने इनको slides दी थी तो rearrange करने में ये सारा गड़बड़ हो गई है. They may present as abdominal mass or abdominal pain or discomfort. Those GIST who are which are in the small intestines, if they are pedunculated, they are likely to cause intussusception and would present as intestinal obstruction. Or sometimes these tumors are very soft and they rupture. And if they rupture into the peritoneal cavity, the patient will come as an acute abdomen, although this occurs quite rarely. So most of them are quiet to begin with, present as GI bleed or large abdominal mass, abdominal pain, discomfort, intestinal obstruction, or acute abdomen in that order. This is another thing to be remembered. Tumors, there are two ways of tumors that they can grow. Most tumors, they infiltrate. They do not respect the anatomical boundaries and they just infiltrate contagiously into whatever structure they which neighbor them. But these tumors are their expansile. They don't infiltrate, they just enlarge, keeping a spherical so-called capsule or cover around them. So this is the lumen of a small gut, and you can see a pedunculated mass, which is with relatively smooth overlying mucosa and some red spots. We will come to that. So they enlarge by expanding and not by infiltrating. Another unique feature which is helpful in the diagnosis of GIST is that they rarely metastasize to regional lymph nodes, but quite frequently they metastasize to the liver and to peritoneum as well. So if on an MRI you see a tumor which is spherical, expanding with a capsule, with mets in the liver and no regional lymph nodes, keep this diagnosis in mind. These tumors have very rare paraneoplastic effects. So that is why they remain quiet. They remain quiet locally, they remain quiet systemically. Very, very rarely they would present as weight loss, cachexia, and hypoglycemia. This is rare. This is exception to the rule. So how do they look like? Endoscopically, they look like a polyp with smooth overlying skin of variable sizes. One typical feature which occurs in most GIST is this umbilication with central area of bleeding. You can see this here, and in fact, this here actually tells that this is likely to be a GIST. You will see it here. Here you can see a bleeding spot, but there are variable bleeding areas here, but they can present just a smooth bulge here and here. So if you're not careful, you're likely to miss this, you're likely to miss this, you're likely to miss this. So it is always a wise thing to biopsy any abnormal structure that you see. This are the gross specimens. I've just projected just to prove that they don't infiltrate. This is the entire tumor. So here is this tumor, and you will see all of them. You see the capsule, expanding capsule here. And the second thing is that you see all these bleeding areas. So we'll talk about it later in one slide next, that if you do a CT scan, how do they look like? The size can be variable. They're well circumscribed. They are not homogeneous. On MRI and CT, they are inhomogeneous. There are areas of necrosis, there are areas of hemorrhage, there are areas of cystic degeneration, and then there are areas which are very vascular. So when you inject a dye, you will see enhancement of the contrast, but not uniformly. It's a variegated appearance. And then you would see that the neighboring structures are pushed rather than infiltrated. So these are some points which will help you come to the conclusion that this is not a carcinoma stomach, this is likely to be a GIST. So you can see a circular, well-preserved capsule of this growth, and it is not homogeneous. This is an arterial phase CT, which shows contrast enhancement, which is variable. This is what I was telling you. There are no enlarged lymph nodes of any significance, but you have a metastatic deposit here. So typical tumor, no lymph nodes, gone to the liver. Again, here you see variegated appearance, contrast enhanced, then black areas, necrotic areas, avascular areas, and in the wall of the stomach. Another useful modality is endoscopic ultrasound, which would show the same feature. And in that, you can actually do a careful biopsy as well. Since many of them would occur in the stomach, so EUS can easily diagnose them. Control of bleeding is just as you try to control any GI blood cause. You have all these armamentarium. You can do endoscopic therapy, angiographic embolization, and surgery. In endoscopic therapy, you can inject adrenaline as we did in our case, but you can also use, you have to assess the tumor and see which modality would be most feasible. So for surface, you can use adrenaline, again, argan plasma coagulation. Hemoclips should be used very, very carefully, because if the surface is friable, the clip will just bite through and increase bleeding. But if you see an artery which is supplying the tumor, and you can see in the normal mucosa, clipping would be ideally done there. Hemospray is also a good temporary measure. If you fail, when we fail, we ask the interventional radiology colleague to help us. So they go in to the artery and they block the feeding artery and therefore control the bleeding. But all these things are just a bridge, because ultimately, if a relatively permanent relief has to come, it has to come through surgery. You can control bleeding, stabilize the patient, assess it, and then do surgery. Or sometimes the patient is persistently bleeding and you have to go in as an emergency surgery. Last slide. Management, obviously for a very early stage, you do surgical excision. And you don't do routine lymphadenectomy because you know that these are unlikely to spread in the lymph node. Then you can, while doing surgery, you have to take great care that during surgery, the tumor may not rupture. Sometimes, if the tumor falls in high risk, you can use adjuvant imatinib, which is do surgery, and then even if the metastases are not there, but you feel that this is a high risk situation, micrometastasis may be present, you start with the chemotherapy. Or if the tumor is very big, you can start the chemotherapy first, that is called neoadjuvant, reduce the size of the tumor, and then you perform organ salvage surgery. We generally almost always do genotyping or immunohistochemistry. And there are various different, as I said, CD117, and then there are other variants as well. They are very important to understand and to perform, to decide which chemotherapeutic agent is needed. Generally, the tyrosine kinase inhibitor group of drugs is used to treat GISTs. I've also already mentioned imatinib, and then sunitinib, regorafenib, and other similar tyrosine kinase inhibitors are used for various types I have intentionally omitted complicated classifications and grading because you can't remember it. So you have to grade the tumor, you have to classify the tumor, and then use one of these drugs which is indicated. But mere fact that we are using this drug and that drug and that drug means that still we are looking for a definitive cure. तुक्के मार रहे हैं. If you study various research papers, so there are various drugs which have been tried, mainly tyrosine kinase inhibitors, but there is no ideal drug found as yet. So in summary, GIST originate from interstitial cells of Kagel. GIST is a rare tumor of GI tract, generally presents as GI bleed. GIST, as a rule, do not metastasize to the lymph nodes. They are expansile rather than infiltrative. Surgery is a definitive cure if the tumor is small, and chemotherapeutic agents of choice are tyrosine kinase inhibitors. So we come to the end of the short presentation. Thank you very much for listening.
So Professor Fawad Randhawa, he's the professor of endocrinology in Allama Iqbal Medical College, Lahore.
Thank you, Okas. I would like to thank Shaukat Khanum and particularly Ahmed for inviting me in this interactive session, and I would like to keep it straight, and it is a very relevant topic because as far as the malignancies and diabetes or hyperglycemic emergencies are concerned, they are quite pertinent in two factors because number one, they are not so uncommon, and number two, they are treatable if diagnosed earlier. Staggering stats. We have the latest stats, 34.5 million people Pakistan. मेरा ख्याल अभी भी under calculated है पूरे सही तरह इसके levels हैं नहीं, but 3.45 3.5 करोड़ पाकिस्तानी diabetics हैं. इसमें pre-diabetes और undiagnosed diabetes नहीं आती. ये 2025 का published data है. Amongst them, new cancer cases are quite high, 178,000, followed by the cancer deaths, which are approximately 125,000 again. So there are two chronic diseases with higher mortality in our local data. Next, shift to this over. Thank you. So what are the challenges of hyperglycemia in cancer patients? Due to the advent of immune checkpoint inhibitors, we are seeing lots of hyperglycemic emergencies. There are 27% basically percentages in which isolated hyperglycemia are present. Amongst them, 3 times there are more likelihood of new onset diabetes in cancer patients. Along with it, there are 40% survival impact, which is a huge impact because reduction in overall survival rate is there if hyperglycemia is not diagnosed and negated timely. Or obviously, there is a high mortality in patients who are having type 2 diabetes complicated with HHS, more than 15%. And lastly, 55% of pediatric survival oncological patients can develop diabetes as an age-mat peers, especially in leukemias and lymphomas. So it's a very relevant stats which comes to this thing. There's a mechanism behind hyperglycemia crisis in oncology. Number one, unpublished and unelevated and unregulated kind of elevation of counter-regulatory hormones, especially the glucagon, cortisol, and catecholamines. They actually causes hyperglycemia and increases the insulin resistance, followed by inflammatory cascade, pro-inflammatory cytokines, which are there in oncology as far as the disease is concerned, as far as the treatment is concerned. So they release both the tumor and the treatment. They causes insulin resistance and protective versus pathological. Initially, a little bit of hyperglycemia is there to protect from the stress, but when it crosses more than 350 milligram per deciliter, for that reason, in fact 20 millimoles, it becomes pathological. So DK and HHS still remains the most common hyperglycemic emergencies in patients. But the challenge here is that oncological patients are not so stable. As you can see in challenge, there are cardiovascular compromises there, so we have to tailor our management. The blanket treatment of DK and HHS sometimes doesn't hold true for these people. We have to monitor them meticulously because the mortality of DK usually is less than 1% in non-cancerous patient, but here it rose because of the complications. And same is true for HHS, more than 15% mortality rate is there. So immediate management remains the same, that is fluid resuscitation followed by potassium hemostasis followed by insulin infusion to protect the acidosis or gap acidosis. But the problem is that comorbids. You have to take into consideration the comorbids, which will tailor your management depending upon the fluid management and requirement of insulin. So of course, you have to treat the precipitation factor. In this case, either there will be a neoplastic manifestation of which can cause the hyperglycemia, or the treatment-related hyperglycemia is there. So depending upon the cause, you have to negate it as well. So corticosteroids remains the mainstay of treatment in any form in patients who are suffering from any kind of a neoplasia, starting from cancer-related symptoms to treatment of drug-related adverse effects to symptoms along with anti-cancer treatment as a part of anti-chemotherapy and prevention of adverse drug reactions. So corticosteroids is basically the cornerstone of treatment of any of these aspects, and that brings to the pathophysiology. So we need to know, why steroids has to be treated in same manner. Along with it, there are certain studies which are actually coming up with other medications along with steroid. In the patients who are receiving steroids, we can manage them along with insulin. There are certain, this is for type 1. As far as insulin adjustment is concerned, depending upon the patient, depending upon the comorbids and age and duration of diabetes, you have to adjust proactively the doses of insulin, both basal and bolus. There's no fixed rule. You have to modify it on an individualized basis. You have to take into consideration the dawn phenomena. Along with it, there is insulin pump is not so uncommon now. So insulin pump, if the patient is receiving CGM along with insulin pump, the basal rate has to be escalated from 30 to 70%, depending on the management. And you have to keep in hand the bolus insulin as well. Despite the fact the patient has having pump, they might be requiring the bolus insulins, depending upon the hyperglycemia and the severity. But remember the most important fact, that if once the steroid exposure is gone, there is a drastic decrement in the dosage and requirement of insulin. So don't avoid this thing, but otherwise you are inviting hypoglycemia in these patients. As far as type 2 diabetes management is concerned, that was I was referring to, apart from insulin, which is mostly basal and bolus. We don't encourage the premixes because it is very difficult to calculate the approximate amount of units in there. There are studies which are encouraging the usage of GLP-1 and DPP-4 based therapy, because the main crux of the matter in steroids is increased gluconeogenesis and decrease in the utilization of insulin because of the insulin resistance. So they actually addresses that pathology. So GLP-1 or DPP-4, don't combine them both. Any of them, depending upon the contraindication. After ruling out the contraindication, you can use them. There are growing evidences there. Also because of the fact that it will enable you to decrease the units of insulin and can avoid you from the future hypoglycemia. So to summarize, in steroid-induced hypoglycemia, you have to stratify the type of patients, the type of steroids, and the duration of steroids, and then you have to monitor them meticulously and with dynamic treatment options, which are many depending upon the types. In type 1, it is insulin, basal, bolus. Apart from this, proactively, you have to modify the units. And then after the tapering of the steroid, you have to come back to the normal. There is a possibility that you can diagnose patient for the first time as being hyperglycemic after receiving steroids. So it is a possibility that after stopping steroids, the patient can revert back to non-diabetic state. So why is there a problem with steroids? This is a pathophysiology I just mentioned. There is a main important pathophysiology is increased gluconeogenesis. which will increase that blood glucose level. Along with it, there is a peripheral glucose uptake is reduced, creating a perfect storm for elevated blood glucose. So this clinical impact has to be taken care of, because that will enable us to choose which medicine to be selected, and requires close collaboration with an endocrinologist to adjust the diabetes management, because it is most important when and where to act. A few words for immune checkpoint inhibitors and autoimmune disorder, because they are very much in vogue right now. So they activate immune system, potentially targeting pancreatic beta cells. So there is a epidemiologically stats of 0.4 to 1.9% of patients that can that it's CIADM can create diabetes mellitus. So decay risk is there because beta cells has been targeted directly. So they will act like insulin deficient, insulin repeated patient. They are at risk of developing decay. Treatment remains the same. And diagnostic challenges are there because their patients are on multiple medicines along with steroids. So you cannot be very confident which type of diabetes is there. So there is approximately 76% of times there are complicated concurrent corticosteroid induced hyperglycemia I just mentioned. So diagnostic workup remains the cornerstone with proactive management. So just two cases, because there were the complicated case study was the type and that there was included in the topic. So I put forward two real-time scenarios, one for type 1, one for type 2. This is a initial presentation of managing steroid-induced hyperglycemia. 57-year-old female with lymphoma developed severe hyperglycemia following methylpred pulse therapy. The blood glucose exceeds 20 millimoles, which multiplies by 18 to approximately more than 360 milligram per deciliter. So intervention was done in the same manner, because the patient was first time diagnosed with hyperglycemia. This was not the known diabetic patient, but the treatment remains the same. This is mainstay of treatment will be insulin. The blood glucose stabilizes in within 2 weeks, allowing continuation of cancer therapy without interruptions or compromise to treatment outcomes. After the completion of therapy, the patient might not be needing the insulin. For type 2 diabetic patient on dexamethasone pulse, there's a 58-year patient with type 2 diabetes having baseline HbA1c of 7.5, which was moderate control, well controlled on metformin and gliclazide. He was commenced on 16 milligram of dexamethasone daily for 5 days as a part of lymphoma treatment. So the acute response was the same, that it is a long-acting steroids. It will invite hyperglycemia. So intervention was the basal insulin was added because he was not receiving any insulin. So depending upon the clinical acumen of the patient, of the doctor, he started off with 40% of starting dose. There was no fixed rule. It depends upon you and the patient and the weight and the comorbids. You can start off with basal insulin because fixed fasting first, FFF, and you can add rapid acting bolus depending upon the trends of the hyperglycemia. So the resolution and follow-up, glucose level normalizes by day 7. Post-pulse completion, insulin doses systematically tapered over subsequent weeks and returning to pre-steroid oral medication, and insulin was stopped. So second last slide, what is the challenge of endocrine or endocrinopathies for that reason, along with patients who are having steroid pulse therapy for any oncological disease? There are clinical benefits of steroids, yet the steroids will invite multiple metabolic storms or disarrangements. So endocrine challenges are there, not only to treat the patient, but also to interpret the different endocrinopathies to start off as a part of the treatment, because there is a typical methylprednisolone pulse therapy is doses approximately 20 to 30 milligram per kilogram dosage. Is a huge dose and it lasts its effect approximately to 1 day. So you have to take it into consideration the duration for which the steroid has to be given. That will help you and decide which medicine and how much time the medicine has to be taken. Last slide. The crux of the matter is early recognition. जितना भी कहें उतना कम है. If you recognize it earlier, you will negate the complications, especially the mortality and morbidity, not only by malignancy, but also by the hyperglycemia, which will be there. So clinical awareness has to be there, which will tailor your diagnosis depending upon your patient and the treatment the patient is taking. Coordinated care is there. It's a multidisciplinary approach, endocrine, and obviously oncologist is there, depending upon the disease you are dealing with. And ongoing research is there, which will enable us to decide or to opt for treatments outside insulin as well, which not only will help us negate the side effect of insulin, but also to decrease the units of insulin. So hyperglycemia in oncology represents the convergence of cancer biology, treatment toxicity, and metabolic vulnerability. Success requires anticipation, preparation, and coordinated expertise. Thank you. So यार एक स्लाइड जरा मेरे ख्याल हाइड हो गई थी, वरना वो भी दे देता, टाइप 1 की माजरत हाइड हो गई है मेरे ख्याल.
It's all right. Dr. Fawad told us that he has got a commitment already and he will have to leave. So for question answer session, I think he has done himself a bit of favor here that he finished early. So if there are any questions for Dr. Fawad, and if you would like to ask them now, please go ahead. And otherwise, if there are any questions which you remember later on, then myself and Dr. Waqas will try to answer that. But this is the time now. If you want to ask any questions from Dr. Fawad, I'm sure he'll be happy to answer those.
कोई नहीं. Thank you.
I've got one for you at least.
Yeah. When you're managing with insulin, ultra short acting insulin and all that, what would be your choice in managing an hyperglycemic episode in a cancer patient?
सर इसके दो आंसर हैं. एक प्रैक्टिकल है जो शौकत खानम वालों को भी पता होगा और आपको तो मुझसे बेहतर पता होगा. सर आपको पता है कि आजकल जो कन्वेंशनल इंसुलिन है, बिकॉज ऑफ द एडवेंट ऑफ जितने भी एनालॉग्स हैं, कन्वेंशनल इंसुलिन प्राइवेटली और जो पेशेंट्स को देते हैं उसके दो एक ड्रॉबैक्स हैं. एक ये है कि टाइमिंग डज मेक अ डिफरेंस, जो कि हमारे जो नर्सेज और बाकी लोग हैं मलूज़े खाते नहीं रखते, खाना खा लिया पेशेंट्स भी नहीं बताते. तो अगर आपने रेगुलर इंसुलिन देनी है, एटलीस्ट 20 to 25 या 30 मिनट्स पहले तो दें टू हैव इट्स अटमोस्ट इफेक्ट. लेकिन वो नहीं करता. तो अक्सर औकात आप देखेंगे सर, कोई मरीज के 300 350 शुगर है, 10 15 20 आर NPH और आर चल रही है, डजेंट मैटर. एक तो ये प्रॉब्लम है. तो आई विल डेफिनेटली प्रेफर, हालांकि अभी तक स्टडीज नहीं है कि द रेगुलर और कन्वेंशनल इंसुलिन आर नॉट लोअर और नॉन इंफीरियर नहीं है, बट the age and the onset and offset of the treatment, especially in patients of oncology receiving steroids, the analogs are things to go, because urgent treatment है, खाने के फौरन बाद भी दे सकते हैं. पेशेंट्स एनोरेक्सिया की वजह से, और पेरेंटल न्यूट्रिशन वाली स्लाइड इसमें हाइड हो गई थी, दैट वाज आल्सो अ चैलेंज. पेरेंटल और एंट्रल न्यूट्रिशन के साथ यू हैव टू हैव अ हाई रिस्क एंड हाई हैव टू कैलकुलेट द इंसुलिन डोजेज. तो उसमें एनालॉग्स का फायदा हो जाएगा, बिकॉज 3 से ज़्यादा दफ़ा भी दे सकते हैं. लेकिन और जो पाकिस्तान में 2-3 अवेलेबल नहीं है, आपको मुझसे बेहतर पता होगा, वो 4 से 5 दफ़ा भी दे सकते हैं एवरी 4 आवर्स. अल्ट्रा शॉर्ट एक्टिंग जो फैस्ट और बाकी सब हैं 4-6 दफ़ा भी दे सकते हैं. बेजल रिमेन्स द सेम. जो सबसे बड़ी गलती है जो मैंने अपने थोड़े से एक्सपीरियंस में किया, कि हम नॉर्मली आउटसाइड एंडोक्रिनोलॉजी के अंदर जो है, नो ऑफेंस टू फिजिशियन अदरवाइज, बेजल्स को यूज नहीं करते. बेजल हम पहले यूज करते हैं. वकास और अहमद मेरा ख्याल है मुझसे एग्री करेंगे, बेजल्स को वो सिर्फ स्लाइडिंग स्केल पे लिख के चले जाते हैं. दवाई भी कोई नहीं चल रही है. बेजल इज ऑफ प्राइम इंपॉर्टेंस. वो नॉन फैट स्टेट के ऊपर जो 99% ऑफ टाइम वहाँ होगा, बेसल विल टेक केयर ऑफ इट. जिस तरह मैं आपसे कहा ग्लूकोनियोजेनेसिस बढ़ा रहा है, खाना खाएंगे तो इंसुलिन वाला समझ, ग्लूकोनियोजेनेसिस को नेगेट करना है. GLP और DPP-4 भी इसलिए हिट हो रही है सर कि अपार्ट फ्रॉम इंक्रेटिन इफेक्ट, इट एक्चुअली सप्रेसेस ग्लूकागॉन, which is a huge benefit, जिसकी वजह से दवाई ये is there to stay. It might answer your question. Thank you. Sorry, मैं जज्बाती हो गया था, जरा आंसर जरा.
Got another question for you.
So Usman here. So excellent talk.
Assalamu alaikum.
Assalamu alaikum. Ji. So
Fawad.
I'm a clinical hematologist and hemato-oncologist, and we do in our treatment regimens we've got a lot of steroids.
Yeah.
Steroids sometimes go for a few weeks or more and pretty hefty doses. So first question is around that. That's a very good idea and suggestion that we can use. You mentioned the GLP-1 inhibitors in that context. So is any specific patient context we should be looking out for, or is there any, it can be given to anybody? Is it like preventative, or when the blood sugar levels go higher up and then we should be considering? That is number one question. Second question is that
यहीं पे मैं दोबारा पूछने में भूल जाऊंगा, बूढ़ा हो गया. अच्छा, excellent question, उस्मान. पॉइंट ये है कि GLP-1 can be taken in any patient except those patients who have contraindication. वो 3 contraindication आप मुझसे ज़्यादा एसोसिएट कर सकते हो, because men 2 का प्रॉब्लम ये है कि we can't screen it. If you are treating a patient of men, और अगर men 2 हो और men 2B होगा, I won't be giving it to play safe, despite the fact कि इसको मेडली थायराइड कैंसर नहीं भी है. फैमिली हिस्ट्री तो नहीं देंगे. पैंक्रेटाइटिस द अदर थिंग, और ऑब्वियसली बाकी चीज़ें तो यहाँ पे सूटेबल नहीं है कि प्रेगनेंसी और बाकी सब चीज़ें. तो GLP-1 देने के 2 फायदे हैं. एक तो it is addressing the pathophysiology which is governing the hyperglycemia and steroids, which is gluconeogenesis and increasing insulin resistance. शॉर्ट टर्म के अंदर स्टेरॉइड आप दे रहे हो, GLP-1 का जो वीकली GLP-1 आई है, इट हैज क्रिएट्स वंडर्स बिकॉज ऑफ द फैक्ट कि वो पूरा हफ्ता बॉडी में रहेगी, तो इट विल इंक्रेटिन इफेक्ट से उसकी रिक्वायरमेंट ऑफ इंसुलिन कम हो जाएगी. लेकिन टू द बेस्ट ऑफ माई नॉलेज, वकास और अहमद कैन वाउच फॉर इट, कि इंसुलिन टोटली मुबर्रा नहीं हो सकता मरीज. The patient will be receiving insulin for that steroid because it comes very in fashion once in COVID में लोग आते हैं, सोलोमेड्रोल है 1 ग्राम TDS सुबह दोपहर शाम, तो उसके साथ तो पेशेंट डीके के साथ थोड़ा बहुत तो मिगोर के साथ भी आया है. तो द प्रॉब्लम इज कि इंसुलिन की डोजेस कम हो जाएगी, द रिक्वायरमेंट ऑफ बोलस विल कम डाउन बिकॉज इट इज एन इंक्रेटिन इफेक्ट, तो पोस्ट मील शुगर्स विल कम डाउन.
So you're talking about the patients who already are diabetic, is that right?
और पेशेंट्स ऑलरेडी आर
On already diabetic, आप उनकी बात कर रहे हैं?
दोनों की. इस तरह दो सिनेरियो होता है. स्टेरॉइड by default creates hyperglycemia. In those patients, GLP-1 is too much to opt for, because if patient is not a diabetic before, he's just having type 3 diabetes, which actually is a secondary diabetes, what you said. Apart from diabetes, you can give insulin, you can give metformin as well, you can give DPP-4, but GLP-1 theoretically can be given. The papers are still lacking. That is the answer to your first question.
Thank you.
Next question.
A follow-up question was that now we've got few cohort of patients who develop diabetes secondary to steroids.
Yes.
And they are young patients.
Yes.
Do they need to be treated a bit differently or managed differently in that context?
As far as literature is concerned, if the patient is not diabetic before and the patient is diagnosed with diabetes, or for that matter hyperglycemia first time after hyperglycemia, you start off with insulin and you can add on the medicines which are actually addressing the pathophysiology, which is metformin or DPP-4. GLP-1, if yes, you can give it after rule out contraindication. If the patient is obese, it is icing on the cake. And you can keep it that way once the steroid has been stopped, and you can reassess the patient whether the patient is requiring continuous therapy of anti-diabetes or not.
Okay, probably I think at that time we get our endocrinology doctors to be with us as well.
That
Thank
would-
you.
Thank you.
Well, this means one thing just to add there, because we see a lot of people with chemotherapy and steroids, which is very commonly used. One of the common problem these patients have, they got a severe vomiting, diarrhea, and that's very, very common in
Yes.
patients who receive chemotherapy. And the problem with the GLP-1 itself is that they can cause the most common
All-
side
all-
effect.
all these
They
side
can
effects,
cause
yes.
vomiting and diarrhea. So that's one of the limitation which definitely
Absolutely.
we always have to be worry about, or especially starting the GLP in that population. The only other thing which probably we will have more in the future, but not yet, is there is a not lot of data of GLP use in cancer patients. There is
Yes.
a lot of data in use in general public, and they got excellent data, cardiac, for nephrology, excellent data. But for a lot of these studies, they normally don't include the cancer patients.
Yes,
A lot of
absolutely.
them,
That's why I said it is a very data will be lacking. It will be most likely depending upon the contraindication. Definitely, if the patient is having any foregut symptoms, irrespective of even indication, you can't give GLP. For that reason, metformin can also not be given. And if the patient is hemodynamically unstable, insulin is the way to go. There's just safe approach is insulin. I totally agree with you. Thank you.
Right, so I think that seems to be, yeah, we don't have any more. Umar, do you have any questions sent to you? Have a look online.
Thank you.
Are there any questions, Umar, online? Yes, I think there are.
So the first question is there any role of sulfonylurea in steroid-induced hyperglycemia?
Frankly speaking, sir ने कहा था, while searching the data and specifically for the last 5 to 7 years, बहुत कम studies हैं. Sulfonylurea theoretically speaking, आप दे सकते हैं, वही वाली बात है, depending upon the fact कि किस चीज़ के लिए steroids आप दे रहे हैं. इस तरह आपने वकास ने कहा था, steroids अगर आप सिर्फ कवरिंग अप फॉर दैट सीरियस इफेक्ट्स के लिए दे रहे हैं, तो सल्फोनेलुरिया वॉमिटिंग के बाद वैसे भी डिस्करेज करेंगे, इट विल एग्रीवेट द हाइपोग्लाइसीमिया. इंसुलिन अगर है तो इंसुलिन के साथ कंबाइन वैसे भी नहीं करते हम. मैं ये नहीं कह रहा कॉन्ट्राइंडिकेटेड है, हर बंदा डिफरेंट ट्रेन हुआ हुआ है. मेरी छोटी मोटी ट्रेनिंग के अंदर मैंने जिंदगी में आज तक सल्फोनेलुरिया इंसुलिन के साथ नहीं कंबाइन किया, वरना बेसल इंसुलिन के साथ दे सकते हैं. इन दिस सेंस मेरा अपना हम्बल सबमिशन ये है कि नो, सल्फोनेलुरिया शुड नॉट बी गिवन. अब आपकी अपनी मर्जी है.
Anything else?
Right. Okay. I think we don't have any more questions at the moment. And as I said, if there are any more, you can let me or Dr. Vikas know and we can discuss it. Thank you very much, Dr. Fawad.
Thank you,
for
Amber.
your time. Thank you. So our next speaker is actually, we got a recorded talk, and that's by Dr. Shahid Sattar Ahmed. He's a medical oncologist specializing in the treatment of genitourinary cancer. He's an attending physician at Winch Cancer Institute at Emory Midtown and is assistant professor in the Department of Hematology and Medical Oncology at Emory University School of Medicine. So we'll have the recorded talk, and Dr. Ahmed will later be available for any questions. He will be available online after the talk. Thank you.
Hello, I'm oncologist at Emory University. I specialize in genitourinary cancers, and it's my privilege today to talk to you guys about spinal cord compression in this section on oncologic emergencies. So moving our slides here. Spinal cord compression is a very common thing that people can sometimes present with in the hospital. Cancer develop spinal cord compression at some point in time in their life, usually at the end of it. Presentation can be synchronous. So at initial diagnosis, when the patients aren't aware that they have a cancer, and that mostly happens in lung cancer or when people have cancer of unknown primary, multiple myeloma or lymphoma. And then, patients who've already been diagnosed with breast cancer or prostate cancer can develop metachronous presentation after initial treatments. So looking at the extent of cord compression, what the pathophysiology is, typically it results from either a collapse or a compression of a vertebral body that is riddled with cancer. Or sometimes we can see direct tumor extending into the vertebral column itself. So with the tumor causing compression, it causes edema, venous congestion, demyelination, and that's what causes all the symptoms that patients present with. If these symptoms persist for a longer period of time, then that can result in cord necrosis, cord infarction, vascular injury, and even permanent damage. And it's very important to recognize these patients early on, because after 48 hours of having neurological compromise, oftentimes they have a very hard path to recovery or do not recover at all. So at this stage, I think it's important to kind of look into what are the high-grade and low-grade types of spinal cord compression, and that kind of tells you about the urgency of your management options. So this is the grading. That's the ESCC grading based on the extent of tumor. So if there's only cancer in the bone in the anterior vertebra, but nothing else, then that's grade 0. If there's cancer that is at the thecal sac, maybe abutting the spinal cord, that's grade 1. And so until grade 0 and grade 1, it usually is low grade spinal cord compression. But once the tumor approaches the spinal cord and the CSF fluid and is now visibly pressing on the cord, and what that's when you have grade 2 or grade 3, and those are patients who have high grade spinal cord compression and need to have evaluation done quickly. So most commonly, it presents with back pain. Almost always there's back pain that's been persistent for the past several weeks or so. So patients who already have a cancer diagnosis, and when they present with back pain, their oncologist should, get an MRI within a week to try to figure out if they are at risk of developing spinal cord compression down the road. The pain usually progressively worsens and oftentimes is diurnal and increases at night. And we think that's because of the changes in corticosteroid physiological levels. There are certain red flags that we have to always ask about. I'm sure a lot of you already know about these, is limb weakness, difficulty walking, any kind of sensory loss, in any dermatomal fashion, whether they have persistent bladder or bowel dysfunction that's new compared to before. Any other neurological signs, any pain anywhere else, those are some things that you're asking for. And then you're also trying to ask about nocturnal spinal pain. So there are several things that we have to take into account when we're discussing management options. There's the high risk, these patients, especially who are at high risk of developing bone metastases, and those who've already had bone metastases before, but don't have spinal cord compression. Those are the patients who are counseled in the clinic and are educated on the symptoms, so that if they develop any symptoms, that should be taken care of. Then there are, so those patients should get an MRI within a week, like I was saying. And then patients who do present with full-blown spinal cord compression, it's a medical emergency, and those patients need an urgent MRI within 24 hours and need to be admitted in the hospital, need to be on bed rest. They are oftentimes started on a high dose of dexamethasone, and then all the neurological specialties and neurosurgery, radiation oncology are consulted right away to kind of come up with a plan. The goals for these patients are, first is that early diagnosis is key. So whenever you can prevent spinal cord compression in a patient with bone metastases, that's going to be very key in preventing neurological compromise. And once they have spinal cord compression, though, your goal is to try to maximize function as much as possible. A lot depends on their pre-existing function. So if they are already were bedbound or had a poor performance status to begin with, there might not be a lot of gain in maximal function that you might be able to get. Obviously, treating the pain and then also preventing neurological complications. So several things here that go into our considerations. Number one is, when a patient presents with metastases, we do need to get a histological diagnosis. So sometimes you need a biopsy. And if patients are going to go for surgery anyways, you don't need a biopsy in that case. So your clinical picture here is going to be of paramount importance. So a patient where you suspect that a lymphoma diagnosis or myeloma diagnosis might be what's causing it, sometimes you need a core needle biopsy to get that diagnosis. And some of those patients might not even need surgery because they can respond pretty quickly to steroids. However, if you were to give them steroids first and you did biopsy later, then you might not get the diagnosis. And so those are the patients where I think core needle biopsies are indicated when there's a suspicion for a hematological malignancy. For renal cell cancers or multiple myelomas, those are patients who are relatively radioresistant. And so for those patients, oftentimes surgery is the first option if they're surgical candidates. And so when they're going to proceed with surgery, they are going to get some tissue at that point in time. And so those patients necessarily don't need a biopsy. Then, you have to determine the urgency of whether, how quickly you need to intervene here. And so that's based mostly on high grade versus low grade. And like I said, low grade is when the tumor It might be abutting the cord, it might be involving the thecal sac, but it's not compressing the cord and it's not moving the cord to the side, and there's the CSF is intact as well. For patients who have spine instability, that is an important clinical thing to determine beforehand, because patients with spinal instability might not be the best candidates for radiation, and surgical approach might be best for those patients. In terms of patients with tumors that are radiosensitive, those are patients who might benefit with radiation, and you have to kind of determine the best sequence for their treatments. Is there a fast-acting systemic agent for your diagnosis? So for small cell cancer, chemotherapy can work really fast. Certain kidney cancers where tyrosine kinase inhibitor is available, systemic treatments can work really fast. Rarely in prostate cancer, just androgen deprivation can result in quick relief. So there are those situations where you're trying to see where your systemic agent is going to fit in, and that might, change your upfront surgical or radiation options based on that. Then when patients present initially without a diagnosis, getting their staging scans, getting their tumor markers to make the appropriate diagnosis. So for example, if somebody is 70 years old, is a male, has multiple bone metastases and a large prostate, just getting a PSA, and if it's over 100, will give you the diagnosis there. So you might not need a biopsy. Similarly, patients with germ cell tumors, your tumor markers can be very beneficial. And then your treatment options are going to depend on the overall prognosis of the patient. So if they have a limited, less than 3-month prognosis because of their systemic disease, it's probably best to pursue a more palliative approach. Getting imaging to determine the extent of the spinal disease, even though the at-risk site or the symptomatic site is where you are going to image, you also want to image the rest of the spine to see what is the burden of disease that they have in other places. Do they need compression in another place? They're probably going to need radiation to multiple places as well, possibly. Sometimes just having a very large burden of disease precludes them from getting surgery because of a poor prognosis. And then, finally, in terms of surgical outcomes, pre-treatment ambulation, have they been walking around before they presented? How good was their ambulation 2 to 3 weeks ago? And whether the duration of their symptoms, if it's more than 48 hours, typically those patients have a harder time recovering. So this is from the MD Anderson, and developing pathways at our institutions is very important to kind of get things done quickly and have a streamlined process. So in this setting, patients who present with pain and neurological symptoms, which is suggestive of spinal cord compression, you want to start dexamethasone 10 milligrams IV and get a stat MRI of the cervical, thoracic, and lumbar spine. In patients where you cannot get an MRI for any reason, then CT scans are your alternative. For cervical spine lesions, you want to put a C-collar on you want to do neurological exams for these patients, and then you want to have a goals of care conversation with the patient to kind of determine the appropriate route, whether you're going to take a more palliative approach or a more upfront approach here. For patients, where you do suspect spinal cord compression, you want to get neurosurgery and radiation oncology on board as stat emergent consults. And usually you need to kind of decide within 24 hours what the next approach is going to be. I think we discussed some of these already. Tissue diagnosis sometimes is needed upfront, sometimes is not. And so sometimes surgery is what are better. I'm not saying that those are the patients where you should always do surgery, but those are the patients where surgical outcomes are usually better. For patients with lung cancer, for example, non-small cell lung cancer, outcomes are days where they were ambulating was about 122 days here for patients who went with surgery first, followed by radiation, whereas it was 13 days for patients who went with radiation. So for a lot of patients, I think if they are the surgical candidates and the prognosis is good, and you should try to do decompression surgery. Prioritize surgery because you might not be able to deliver radiation in a safe fashion for these patients. In terms of where radiation might be more appropriate, so this better long-term outcomes and less chance of failure. But the overall survival was very similar in both groups. So for patients who have a relatively reasonable prognosis, I think long-term is the better thing to do, so in 10 fractions or so. But for patients with poor prognosis, I think just 8 grade fraction times 1 oftentimes will help alleviate their pain. XRT should be done within 24 hours whenever possible. There's, for low-grade cord compression from a relatively radio-resistant tumor, considering SBRT to avoid surgery is a possibility. So these are patients where they have a radio-resistant tumor, and your conventional external beam radiation therapy might not be as helpful in preventing recurrence, and you want to be able to reduce their chance of developing cord compression down the road. So SBRT allows you to get higher doses of radiation into that area. And because it's low-grade compression, so there is a separation between the cord itself and the thecal sac and the tumor. Then SBRT, the spillage of radiation and causing symptoms from that, the chance of that is less with SBRT. Whereas with high-grade cord compression, SBRT usually, we don't know if it's better than surgery. There are certainly studies going on to figure that out, but there is a concern that because it's right next to the cord and involving the cord, that delivering these high doses of radiation might cause side effects down the road. So especially including radiation myelopathies. So for high-grade cord compression, considering surgery upfront is a good idea. And after surgery, you could do post-operative SBRT because by that point in time, you've kind of separated the cord from the tumor itself. And surgery, actually, when you're planning for SBRT afterwards, the surgery might be less invasive too, because you're not trying to get rid of all the tumor, but you're just trying to get rid of enough tumor so that it's separated from the cord, and now you can deliver high doses of SBRT. And so this is particularly a beneficial approach for patients with radio-resistant tumors. Very important that after patients undergo their surgical and radiation treatment options, oftentimes, also starting systemic therapies shortly thereafter, that there's a need for rehab for these patients so that they can improve. There's a need for thromboprophylaxis because they're going to be immobile for a while. And then, prognosis is improving with better outcomes because of better surgical outcomes, better SBRT outcomes. There's role for kyphoplasty and vertebroplasty in patients with low-grade spinal cord compression who are having just pain. So that can certainly help with pain. So there are these newer modalities that have come out, and so outcomes are improving. But there are still, a lot of challenges. So need for a multidisciplinary care is very, very important. So with that, thank you so much for having me over at Shaukat Khanum Symposium. It's been my absolute pleasure, and happy to take your questions. Thank you.
Right. So now we come to the end of all our three talks, and I think we just start the question answer session. If anyone has got any questions to begin with the gist and related GI bleed, or with the cord compression, or even related to hyperglycemia. If there isn't one, I'd like to kickstart. So with the GI bleed, I would like to ask from Dr. Arif that we have now recently been referring patients to our gastroenterology team with GI bleeds, and I have noticed, maybe some of my colleagues may have noticed as well, that we're getting more suggestions and advice that we do a CT angiogram before doing a scope. Is there a change in trend, or is it more specific to cancer-related bleed where the angiogram will be more productive rather than a scope?
I don't think that's a trend. I'm sure it must be something to do with cancer bleed. Because if there is a bleed in cancer going on, I think the size of tumor is large. It is more of a widespread ooze or a rapid ooze, for which endoscopically it is very difficult to do something. So it's better to find a feeding vessel and block it rather than to do from the top. So I think that might have been the reason. And they might have experienced that in cancer bleeds, there might be a lot of recurrence when you do endoscopic treatment. And by doing interventional treatment, perhaps that recurrence might not be that frequent. I have a question for Dr. Shahid. Thank you very much for your talk. I was wondering if in a cancer patient, you determine that there are METs in the spinal cord and it has not caused any cord compression. Can you do something preemptively to try and postpone a cord compression?
Absolutely. Yeah, I think, I try my best to identify any sites that are at risk of developing cord compression down the road. And you're particularly looking to see if the cancer in the vertebral body of the vertebra if it's encroaching on your cord or your the dura there, then I think I usually ask my radiation doctors to kind of come in at that point in time and deliver some radiation to that site beforehand. Also, if they start having any pain, I think that you can use SBRT to prevent that from progressing into cord compression, because pain oftentimes takes about maybe 6 weeks, 7 weeks before they kind of start developing neurological symptoms. So once patients have pain, I think that's a sign that you need to kind of involve the radiation doctor.
A question for Dr. Shahid. Dr. Shahid, you mentioned that there is a group of cancers where the outcome of surgery is much better than the radiation, and the group is breast cancer and prostate cancer and lymphomas. So is there any particular reason that they do better if they have surgery rather than radiation?
Yeah, so in those tumors, so lymphomas in particular, I think that they do better because they've got great systemic treatment options after they've had surgery. So I don't know if the surgery really is what is making their long-term outcomes better. I think it's really the very good systemic options that you have afterwards that are probably the reason for why outcomes in lymphoma are better. For breast cancer, same thing, we've got great treatment options. And once you get the patients through their initial phase where the cord compression is better and their symptoms are better, then we have a lot of systemic options there which can control the disease for a long time. Prostate in particular, I just saw a patient the other day. He couldn't walk at all, and it was maybe within 24 hours that he was able to get surgery. And he had widespread metastatic disease everywhere, and he's on systemic treatments now, and it's been 2 years now already, and he's walking, and he's all the way back to being normal. So I think at the end of the day, it's about the disease itself, that it's got good prognosis because of the treatment options available. And surgery is like that quick fix that can get you through that hump initially. And so I think that's probably the bigger reason for that. I'm not sure if there are surgical outcomes are better because the tumor biology, the removing the tumor is easier, or I don't think that's as much of a big factor in that.
Right. I've got one for you, Dr. Shahid. It's rather basic question, I would say, but I can see some of the trainee doctors in the room that maybe benefit for them. So in terms of the spinal cord compression, you mentioned that we should try to get a diagnosis if we can. Now, in our setup, we say the pathway is to do an MRI scan within 24 hours, and most of the time we end up getting it sooner than that. You would say 12 to 14 hours. And giving steroid is a knee-jerk reflex. You just see somebody suspect cord compression, give dexamethasone, give PPIs, check blood sugars, and that's a rubber stamp, you can say. Now, how often in your experience do you think we need to stop and think that we may need to diagnose first if that has to be? Because most of the time you may end up seeing a patient 1 o'clock in the night. The juniors are there mostly looking after the patients. And how much should we tell them that you really have to stop before giving steroids? Because at the most, you may end up giving 1 or 2 doses of dexamethasone before you will have the scan.
Yeah, absolutely. I think, lymphoma really is the biggest reason where you kind of have to be careful about that, because your diagnosis can become in question after steroids. But I think anybody who is symptomatic, you have a short window of opportunity before they become completely paralyzed. And so I tell my trainees that it's not wrong to start the steroids. If you did, in the middle of the night, it's okay. Because at the end of the day, if the patients are feeling better after that, at least you have, in the short term, prevented, a catastrophe. But I think whenever you're suspecting lymphoma, which radiographically, sometimes, your radiologist can tell you that they have a high suspicion of lymphoma. I will usually check an LDH for those patients to kind of see if that's super high. Could be a marker of that. If you have a PET scan available, that can sometimes be helpful to kind of also figure out if you want to do a core biopsy first. And if you have myeloma numbers, for example, you could send SPEP, UPEP, serum protein electrophoresis, kappa, lambda light chains, all that stuff. And if that comes back fairly quickly, then you could hold off. But I think that first dose of 10 milligrams of dexamethasone, pretty much everybody gets, regardless of what the diagnosis might be. And I think there's little harm in doing that, and probably more harm in not doing steroids at that initial phase.
Right, thank you for the answer. It doesn't look like we got any more. Oh, we got a question in the room. Yeah, go ahead, please. If you may want to come up to the mic, please.
So what do we do for patients who are not fit for surgery or either radiotherapy? So what options do we have for them?
So patients who are not, yes. So patients who have who have cord compression surgery and radiation is not an option, then you kind of think about their prognosis and if they are candidates for systemic treatments. That's what you want to do. I think discussing prognosis is important. Some patients have leptomeningeal carcinomatosis by that point, or have extensive involvement in multiple areas. If their performance status is poor and that's why they can't do surgery, then sometimes discussing, best supportive care, hospice, end of life is also important to kind of have that discussion with your patients. Because treatments at that point usually are palliative. But palliative radiation can easily be performed. I think in the majority of patients, there aren't many people who are not candidates for palliative radiation, and especially that 8 grade times 1 fraction. You can do that easily without any major side effects and can alleviate pain. So, but your goals change. I think when you can't perform definitive surgery, your goals do change, and they become more palliative.
Thank you.
Right, I think that's no more questions in the room. I would like to thank the speakers, Dr. Arif Siddiqui, Dr. Fawad, who has left us already, and Dr. Shahid Sattar for taking time, giving very helpful and useful talks on these very important topics, which we see on kind of daily basis in acute units. So thank you very much. All the attendees who joined us here, and it was a nice session. I'll just call it end for the session. Thank you.